Today I'm going to show you something that once you see it, you can never unsee it. Something that will fundamentally change how you view daily MME and the 90 MME per day threshold. The study was funded by FDA and Department of Justice, but the views are not necessarily endorsed by these agencies. Maybe they will be someday. The materials from this analysis are also freely available, and we're giving universal permission for reuse. The details are all available at go.unc.edu/MME, and the paper has been accepted at Clinical Journal of Pain and should be available in a couple weeks. We've also translated all the SAS code, Python code, and Stata code to help others using these metrics. We'll get our code up there soon. And as I speak, the slides should appear on Twitter. We're doing a little bit of an experiment with links to papers and additional resources. We'll see how that goes. So far in this workshop, we have heard a lot about how conversion factors are imperfect. The purpose of this presentation is to show you something new. We reveal that there are even more fundamental and more influential issues with daily MME calculations than conversion factors and pharmacology alone. The problem is that there are actually 4 different ways to calculate MME per day, but these differences have been entirely overlooked. The solution we offer is a clearer understanding of how to calculate daily MME and how to choose between the different definitions. So daily MME has been enshrined into law in 14 states, which make the assumption that daily MME is a standardized clinical metric. But MME is not a standardized clinical metric. None of the laws define how to calculate MME per day because they assume that it is a clinically standardized metric. To start with, let's imagine that we give 4 analysts the same data and ask them to identify which are the quote-unquote high-dose opioid analgesic patients. Same time period, same location, same patients, same prescription, same identical data set. We can even specify which conversion factors to use and tell them to use 90 MME per day to define high dose. And then we can tell them to only use daily MME definitions that were vetted by and cited in the CDC guideline. Sounds like a pretty boring experiment, right? Well, this is how it plays out. Each of the 4 analysts identified a different set of patients who are high dose. They agree at the extreme top and bottom of the range, but in the space where most what happened? To get to the root of the problem, let's give the same 4 analysts a simple scenario. Here's a patient with 2 prescriptions. They're both prescriptions are dispensed on the first day of a 30-day month. We modified this example that appears in the CDC CME training module by adding 1 more script. If you're following along at home, you may want to screen cap this slide. I promise this won't be more complicated than basic arithmetic. So the first script is 30 mg ER oxycodone twice a day for round-the-clock pain for 30 days. So we're looking at 60 tablets, which have 2,700 mg MME, assuming a 1.5 conversion factor. For the second script, it's 5 mg oxycodone twice a day as needed for breakthrough pain for the first 7 days, 105 mg. So for a total of 2,805 MME between the scripts. Okay, so you might want to jot down 2,805 because you'll see that number again in a moment. 4 analysts would actually disagree on how much daily MME this patient is getting. Their calculations will range from 35 to 105 MME. Oops, I'll move the slides. Okay, half are saying that this is a high-dose patient, the other half are saying they're not. This same thing could happen across doctors within the same clinical practice if their definitions aren't standardized, or between a prescriber and an insurance company. So far, in this workshop, we've concentrated on the MME part of MME per day. The numerator is what we've concentrated on. What we haven't considered is the denominator, day. To borrow a line from the musical Rent, how do we measure a day in the life of a patient? I'll spare you by not singing the chorus, but you get the picture. Next, I'll show you how these 4 measures were derived. We took a careful look at all of the studies cited in the CDC guideline to justify the 90 MME threshold. Of these, we found 18 that use daily MME. We combed over the methods and appendices and reverse engineered the underlying equations, which none of the papers explicitly included. Look, my own paper is on here, and I'm just as guilty as everyone else, and I apologize. So this is something I'm doing here today to rectify some of my own past mistakes. In the accepted paper accompanying this presentation, we reproduced the verbatim extracts from each of these 18 papers, some of which I'll show you in just a moment. I know it's a little hard to believe, but the 18 studies used to establish the threshold silently used 4 different definitions. In some cases, the same authors used different definitions between studies without any comment. So this possibly can't be a big deal, right? Well, let's find out. So to atone for the lack of detail in my own published studies, I worked with Alan Kinlaw to reverse engineer these equations. At its heart, the 4 definitions are measuring different things. What we are building to here is that 90 MME is not a standardized clinical metric. We face this challenge in other parts of medicine, like with prostate-specific antigen tests, but we haven't even noticed that it's happening in pain medicine. Next, I'm going to show you some equations, but if you don't speak scientific Greek, that's okay. Just focus on the numbers. This slide is here for completeness. We've heard lots of brilliant discussion about the pharmacology, right? But that's not something that most patients and even most doctors feel comfortable challenging. In contrast, what I'm about to show you is nothing more than basic arithmetic. You can do this at home. I think Dr. McPherson said it best yesterday when she said, call a third grader. Ready? We're going to briskly walk through and see how these equations apply to that 2-prescription scenario you saw earlier. The first definition we call total day supply. In this definition, the numerator is 2805 that you saw earlier. The denominator is 37 days. The denominator is 37 days. Adding up the days supply for the 2 prescriptions, 30 and 7. Dividing these numbers, we get 75.8 daily MME. This is the most common definition used in the literature, and it's this paper by von Korff is the one that's by far the most commonly cited for definitions. Dr. Zhang yesterday pointed out that this was also cited in the printed CDC guideline, conferring with it de facto credibility. And this is the metric that often shows up in clinical data dashboards, including PDMPs. 2 things to note. First, the day supply can exceed calendar days. That's weird. Second, this definition is perverse. By adding a second script for breakthrough, you actually get a lower daily MME. On a clinical basis, this measure doesn't make a lot of sense at all. But on a population level, I see this citation and measure used all the time, in part because it's so easy to calculate at large scale. The next definition is similar, but takes into account overlapping days, so the denominator is 30 calendar days. Dividing by 93.5, dividing, we get 93.5 daily MME. Just with this subtle change in denominator, we end up on the other side of the 90 MME threshold. This probably makes sense to most clinicians, but it was only used in 2 out of the 18 studies cited in the CDC guideline. This is also the method that the HHS Office of the Inspector General recommends, and they provide a handy set of tools to calculate it in SAS, R, and SQL. The third definition uses a fixed number of days for the denominator. Clinicians may be baffled, but this is actually the method that's used in a lot of papers in the CDC guideline, and in the single most cited paper on the risk of dose and overdose mortality, which is this paper by Kate Dunn. This definition has also been used in CDC published studies. Going back to 2805 for the numerator, when we put 90 days in the denominator, we get 31.2 daily MME. This method gets used a lot in research, but it's unclear if those findings would have clinical relevance. In the studies cited in the guideline, 90 days was most common, but some studies use longer periods of time, up to 365 days, further shrinking the daily MME. And inpatient Medicare studies often use 13 days because that's the reimbursement cliff. We went with 90 because that is the most common. Finally, the fourth definition, D4, is something we call maximum daily dose. This is the definition used in the mobile app for clinicians that accompanies the CDC guideline. They call this the total daily dose in their publications, but we think maximum is a better word because it reflects the equation better. This definition ignores day supply and dates for the prescriptions. It assumes the maximum dose on one day, ignoring intentional self-harm. Using this definition, 90 MME plus 15 gives us 105. Not surprisingly, as you'll see, max daily dose returns the highest measurement. This definition is actually a bit tricky to implement with staggered start overlapping scripts, but we've shared our code to help. It's worth noting that this definition is different from the one suggested by HHS, Office of the Inspector General, so here we have two federal agencies saying different things on how to calculate this very essential metric. One of the analysts on our team, Yanning, works with software engineers who process PDMP data and other large data sets. She has been frustrated that most software vendors won't even give you enough detail to know how MME per day was calculated, let alone explain it in terms for clinical decision making. This is calls into question the evidence base that underlies some of our fundamental understanding. So we established that there are 4 ways to calculate daily MME. But hey, is this all just academic? Fair question, so let me show you. We did a controlled experiment. Imagine we have 2 places, and we observe that one place has higher opioid prescribing rate than the other, 8.7 versus 7.9 per 100 adults. This is exactly the setup used in a lot of policy and intervention evaluation in epidemiology research. For our purposes, the cause of the difference is less important. Let's just agree that a difference exists and that we want to measure it. Given the mild imbalance of rates on this slide, we may want to know a little bit more, like if there's a difference in the proportion of high-dose patients between these 2 places. So we did a study comparing 2 locations like we would in a policy intervention analysis. We conceptualized this as if these were 4 different papers using the same exact data set, evaluating the same exact intervention or policy. The key thing to remember here is that the only source of variation comes from the 4 definitions. Here are the methods. We used outpatient dispensing data from PDMPs in California and Florida. We chose a short 3-month period to avoid secular time trends. We defined high dose as greater than 90 MME, and we looked at solid oral and transdermal opioid analgesics. Patches should have been mentioned on the slide, my apologies. And we used the CDC conversion tables for equianalytic potency. Equations allow you to substitute other potency factors, but we held them constant here because we're focused on the denominator. For statistical analysis, we did 3 main things. First, we compared the percent of high-dose patients between Florida and California, varying only the definition of daily MME. Second, we quantified the milligram difference in average opioid dose per day, varying only the definition of daily MME. Third, we conducted a meta-analysis, seeing if 4 different studies using the same data set and the same conversion factors would have statistically agreed with each other. This method is used a lot in observational studies and clinical trials to evaluate if a set of studies are even comparable, if they measure the same thing. This was a method that we applied, that we borrowed from colleagues at FDA who presented something similar at an AdCom last year. Thanks, guys. So for sample size, we have about 9.5 million prescriptions representing about 4 million patients. The numbers you saw earlier were real. Here's the 3-month dispensing rates for California and Florida in the 3rd quarter of 2018. We chose these places because these are 2 of the 3 most populous states in the country, and for good measure, I'll show you preliminary data from Texas as well. Okay, here are the California results first. Same data, same conversion factors, but definitions D1 and D4, which are both used in clinical practice, show a 3-fold difference in who is perceived to be high dose. Adding in the Florida results, we see a similar story, with D4 really identifying a lot more patients, identifying a lot more high-dose patients than the other 3 definitions. Remember, the clinicians who might be skeptical about the fixed 90-day denominator, definition 3, well, guess what? D1 and D3 are actually pretty similar. It's worth pointing out that the definitions perform differently in each state. While D3 returned the fewest high-dose patients in California, it was D1 that was the lowest in Florida. We also have preliminary data from the Texas PDMP for the 1st quarter of 2020 at the outset of the pandemic. You can see a similar pattern across the 4 definitions, but the overall proportions are lower. This could be due to time trends, but also that Texas tends to prefer IR hydrocodone way more than other places. But the takeaway here is, across the 3 largest states in the country, these definitions disagree whether hundreds of thousands of patients are high dose or not. Taking the same data, if we were doing a policy or intervention analysis comparing the two places, the 4 studies on the same data set wouldn't even come close to agreeing. There was 39% more was there 39% more high dose patients in Florida, or was it 84%? Those are big, big differences in terms of policy interpretation. In fact, the heterogeneity from definition alone is so high that we wouldn't be able to combine these into summary measures in a meta-analysis. This really calls into question a lot of what's published in the scientific literature, in epidemiology studies at least. Okay. Instead of percents, we may want to know how much higher doses were given in one place versus another. The 4 definitions don't even agree if the average ER-only pain patient is getting a high dose. We're going to look at those data a little bit more carefully here. So we are still comparing milligram differences between Florida and California. The vertical axis is average MME per day. Each blue bar is a different definition. The way to read this chart is that the bottom of the bar is California and the top is Florida. Florida is always higher. The height of the bar is how different the states are in terms of average milligrams of MME. Using maximum daily dose, D4, you get a really big difference. But these numbers are really all over the place. Okay, all right, ready? It gets worse. The means were highly right skewed, meaning ultra-high dose outliers were driving averages to be unnaturally high. In these situations, we turn to medians in orange, as some of the published studies do as well. Here's where things get even more interesting. D4, all right, whoever's touching the slides among the other speakers, please lay off. D4, which exaggerated the differences between states using the arithmetic average, actually returns much less variation between states in the median. D3 median shows the least difference at 0.9 mgs. The message here is that subtle choices have major consequences for policy and intervention evaluation. Which one of these is correct? I honestly don't know. It depends on the research question is our usual answer, but it's not as simple as choosing something in the middle, though that's our natural cognitive tendency. Each bar on this plot could legitimately have been justified in an observational study and glossed over in the methods section. It's a mess. While they all point to doses being higher in Florida, they really call into question what is actually being measured. In policy and intervention studies, even small effects with large data sets can carry a lot of inferential validity. My recommendation is to let go of the 90 MME threshold and odds ratios that have been used in these types of studies and instead treat MME as continuous and use multiple metrics. At the very least, please, please, please state the definition or equation that you're using. How do these definitions impact our interpretation? Well, using D3 and medians, you could conclude that there are a lot more high-dose patients in Florida, but they're only getting 1 milligram more. Or you could conclude that there are definitely more high-dose patients in Florida, but observing. When you break this analysis out by IR and ER, you see lots of heterogeneity, so much so that a meta-analysis would conclude that these studies were so heterogeneous that you can't combine them to summarize. The other incredible thing here is patient selection. In pharma-sponsored observational studies, you sometimes look at only people who are getting ER opioids to make the cleanest possible comparisons if you're comparing between ER opioids, without the additional confounding of breakthrough pain IR opioids. If we did the study on ER-only patients alone, we would actually conclude that California had the higher opioid doses, not Florida. Again, subtle choices, major consequences. So why is this happening? Despite variation in underlying definitions, the studies cited in the CDC guideline consistently found an increased risk of fatal overdose above 90 MME. The simplest explanation is that it is an artifact of turning a continuous metric into one that is categorical. All but 2 of the studies in the guidelines, cited in the guidelines, categorized MME exposure using 90 to 120 milligrams as the lower bound for the highest stratum, meaning everything else above 90 or 120 was homogenized. Our study supports FDA's contention that overdose risk with opioid analgesics is actually a continuous function. A big part of the issue here is overlapping scripts. These really impact how the definitions perform. So how common are overlapping scripts? 42% of prescriptions overlap with another script in our sample. It affected 1 out of every 4 patients, including most long-term patients. Let me address the epidemiologists and statisticians in the audience. It may seem that choosing one definition and applying it over time would be less worrisome. In most other countries, this is true. However, when you look at the equations carefully, 2 specific time trend scenarios emerge as problematic in the United States. First, if overlapping scripts decrease over time, choosing definition 1, total day supply, will attenuate intervention effects compared to definition 2, differentially at earlier time points. Second, if ER and IR dispensing don't decline at the same rate over time, so non-parallel linearity, this same thing will happen. Both of these prescribing trends happen in the US over the past decade. So the choice of definitions has some special context in this country. We're doing some simulation studies to quantify this, but in preliminary work, the differential effect could be as high as 33% of the intervention effect. So the point here is that subtle choices in measurement have major consequences on interpretation of interrupted time series analyses. We also explored what happens at the threshold boundary, comparing 90.0 as a threshold to 90.9. Where precisely do you draw that line for high dose? Published studies often don't make that very clear in the words that they use. If you shift the high dose threshold from 90.9 down to 90.0, you increase the number of high dose patients by 15%. That means there are a lot of patients who are being held at this artificial threshold despite the definitions not being clinically standardized. June, an analyst on our team, thought this was unexpectedly huge, and I totally agree. He points out that these little changes in studies can lead to misclassification. So we quantified the extent of misclassification. Think of this like a doctor and an insurance company setting the threshold on either side of that very tiny boundary, 90.0 or 90.9, something we would just think of as rounding error. Using definition 1, the insurance company and the physician would disagree for 1 out of every 56 patients whether the beneficiary was getting a high dose or not. With definition 4, it'd be 1 in 30. It's worth noting that definition 3 is the most robust to this kinds of discrepancy, and so for certain kinds of epi studies, it might have some relevance. So, to cover some of the limitations. So we've assumed that all medications are taken as directed, and we've combined cancer and non-cancer pain, looking across the board for opioids. So there's plenty of other pharmacological issues that we've talked about already, but because we're not combining this with an outcome measure, we're just kind of doing it as a simulation study, some of these issues are a little bit less relevant. So which definition should we use? Tosca from our team has a succinct reply. There's no one-size-fits-all approach, but at the least, we need to be showing our work. As a side note, we're doubly proud of Tosca for this past week being enrolled in the first class of the U.S. Public Health Service's new reservist program. So congrats, Tosca. We've heard lots of reasons for clinical caution using MME. So let me address this in terms of epidemiology and policy intervention evaluation. I don't think D1 should be used, period. D2 is the version I use. D3 is more robust misclassification, so if you have messy data, this may be attractive. It also might be really good for long-term studies where there could be gaps between script refills and things like that. D4 could be useful for very short-term toxicity studies in opioid-naive patients where you don't have a risk of suicide, but definitely not for long-term situations. Its inaccuracy actually grows with time. So you can intuit that from staring at the equations long enough. But candidly, right now, if a paper doesn't sufficiently define how they calculated daily MME, I don't read it. I don't read the results. I just can't make sense of it after having done this analysis because these metrics are so fundamentally different. We're also building a research tool to help select metrics. Here's a screen cap of the prototype. If you want to be a beta tester, please drop me an email, which you'll see on the last slide. We're going to try to help some decision-making from the research and policy and intervention evaluation side. So in conclusion, let's turn to the folks with lived experience. Do the patients and the clinicians actually think these definition choices matter? Here's how this plays out in practice with payers. Arkansas Medicaid required beneficiaries with greater than 250 MME per day to be tapered to 90 mgs during an 18-month period. Yet, we saw how D4 is not ideal for patients already on opioid therapy. But using the CDC mobile app, this could easily be the definition applied here clinically, while another prescriber may choose on-therapy days, say definition 2. The bottom line here is that 90 MME cannot be considered a hard threshold because it is not a standardized clinical metric. Dr. Chidgey, who's one of the panelists here today and an author on the study, had this to say. While payers insist they're not dictating care because the patient can still pay out of pocket for the medication, I have many who do, for most patients this is not financially feasible. She also emphasizes that proper pain management truly typifies the art of medicine, which we've heard from other speakers over the last 24 hours. We also asked a pain patient representative on our team to weigh in on the analysis you just saw. So Liz Joniak-Grant, who often is on FDA advisory committees as well as the patient representative, says, far too often we are victims of the good intentions of those wanting to do something about the opioid overdose epidemic. But the something that is done oversimplifies the problem and pushes cookbook medicine upon those of us with complicated medical situations. So we wait and we suffer and we hope it will get sorted so we can get the care we need. And finally, Chris Selcher, one of our other authors, points out that this work is an example of how we can put PDMP data to work positively for patient care. We acknowledge that a lot of patient experiences with PDMPs might have been negative in the past. But in this case, we worked closely with the state PDMPs for this analysis and had the opportunity consequences. All right, so here's my key message. Subtle choices have big consequences. What we have seen here today, and reinforced by all the presentations, is proof that daily MME is not a standardized clinical metric. For the first time in public, we reveal that simple arithmetic might have a stronger impact on MME per day calculation than pharmacology alone. Why had such a measurement failure not been detected sooner? Here's my take. The computational ease and the evocative lure of molecular fundamentals collide in an optimal level of cognitive complexity to engender MMEs with an unsubstantiated aura of immutability. They're not immutable. If you are a researcher, please, please, please state your definition. Feel free to reuse our equations or slides or code. In this way, we can be allied with patients to reduce the most harm with the best information. Thanks to FDA, Dr. Che, and the rest of the team for organizing, and thanks everybody for sticking around.